Hi, this is a part 2 of the lecture titled How to Recognize MRI Sequence, a Simple Approach Beyond the Physics. Please revise the part 1 before you starting to watch this video because it's highly connected with each other. In the last video we have learned some important points. The first point, how to differentiate between the major group of sequences, spin echo and gradient spin echo families. Additionally, the common spin echo pulse sequences like T1, T2 proton densities, and we have talked about special techniques, fat suppression techniques, and we discussed one of the common four techniques on this group, which was fat set with T1 and T2 sequences. These are the four common sequences we give hint about in the last video, and we discuss in detail the fat set technique. In this video, we'll discuss in details the remaining techniques, stir sequences, chemical shift, and Dixon method. Before we talk about the fat suppression sequences in details, I'd like to give you a hint about the important types of fat you can find it in the human body. We have two major types of fat in the human body. The first one is macroscopic fat. This macroscopic fat, which we can see already by the imaging, like subcutaneous fat or abdominal fat, as we discussed in many images in details in the last video. So we can see it by the through the images. And this macroscopic fat could be detected by either fat set technique, which we discussed before, and stir sequences, which we will discuss in the next few slides. Another type of fat, what we call it microscopic or intracellular fat. This fat, it couldn't be demonstrated by the naked eye in the image because it is intracellular. So it doesn't give the signal intensity of the macroscopic fat. So you cannot detect by the eye, but you need special techniques to detect it, like fat set technique, like Dixon method, and chemical shift sequences, which we will talk about. This, this microscopic fat, you can find it in many lesions, especially one of the commonest lesions you can find it in everyday practice, like adrenal adenomas. Also, microscopic fat could be present in other common pathologies like hepatocellular carcinoma or renal cell carcinoma. So in some situations you need to know, is there a microscopic fat or not, because you will limit your differential diagnosis so you can easily reach to the final diagnosis. So let us talk about the stir sequence. Stir sequence has a long name. It's called short T1 inversion recovery. And it belongs to another group of MRI sequences called inversion recovery sequences. This group has a special uses and techniques, and will give a hint about the common sequences belongs to this group in the coming slides. A stir sequence has two main advantages. The first one, it's highly sensitive to the water. The second one, it has homogeneous fat suppression superior over the fat set technique. Thus, this sequence is very important in the musculoskeletal imaging and other imaging of the body parts like the head and the neck, body imaging, and even could be used as a screening sequence for the whole body lesions. This table shows the main difference between STAIR and the fat set technique. As we have mentioned before, STAIR has a high sensitivity to the water content lesions, so it's very important in the musculoskeletal imaging, especially for the bone marrow lesions detection. So if we have a same case imaged by both STAIR and the fat set sequences, you can find that the lesion more obvious and more clear on a STAIR, while it's less clear and may not, and sometimes you will not find it on the fat set technique. So it's very sensitive for these occasions. Another feature, it's very important for MCK, it's less sensitive for metallic artifact. And this is a common scenario in MCK when you are imaging a body part with a nail fixation or intramedullary nail. You will find that a stair has less susceptibility to artifact compared with the fat set. Also, it's a sequence of choice in low magnetic field. So if you have a two machines, 1.5 Tesla and the other one 3 Tesla, you prefer to use to use a stir sequence on the 1.5 Tesla. Will be more sensitive. One of the major disadvantages of the stir sequence, it couldn't be used with the contrast studies. Why? Because simply it will suppress all the signals came from the gadolinium. So the image appears as it is, there is no contrast. But one of the major advantages of the fat set technique, it could be used with the contrast studies. This is an example of a stir image and the T1 sagittal lumbar spines. We can see the yellow arrows refer to the normal bone marrow signal intensity in both sequences, bright signal on T1 and suppressed sequences on a stir image, while the white arrows refer to the low signal intensity of the affected vertebrae. There is indicates that there is abnormality, there is underlying pathology. When you apply the stir image on the same vertebrae, you find that these vertebrae became bright, have a bright signals, indicating there is a significant edema, a significant pathology. So, in addition, the intervening disc has a bright signal too. This is a clue for the spondylodiscitis infection case. And this example indicates the high sensitivity of the stir image for detection of the abnormal water and edema. This is another example show the ability of a stir image to suppress the fat even in presence of metallic implant. We have axial image at the level of the ankle joined with metallic implants on the T2 fat set technique. There is almost no suppression of the fat, and the fat still bright in signal either in subcutaneous or the bone marrow, while on a stir image we can see there is almost suppression of the fat, including the subcutaneous fat and the intervening muscle fat, with almost the bone marrow. It's not complete, however, there is almost suppression, homogeneous suppression of the fat, and this is indicate the superiority of stir sequence over the conventional fat set technique. Now I will give you a hint about the inversion recovery sequences and the common sequences belong to this group. There are two common sequences belong to the inversion recovery sequences. One of them is stir, which we already have discussed in, and the second one, which is common and very important in the brain imaging, is called FLAIR sequence. So what about the FLAIR sequence? FLAIR sequence it's called fluid attenuation inversion recovery. So from its name, its function is to suppress the signals come from the fluid. So by doing so, any abnormalities remain high, but any normal fluid in the case of brain CSF is attenuated and made dark. So there is a high contrast resolution between the lesions and the CSF. And this sequence is very sensitive to pathology and makes differentiation more obvious between CSF and the abnormality became much more easier. The FLAIR sequence is similar T2 weighted image, but it has a very long TR and TE. We already know that T2 has a long TR and TE, but the FLAIR has a very long TR and TE. We already discussed these images before, and you know how can we discriminate between those three sequences, T1, proton density, and T2, and we know that we use the fluid signal as a discriminator factor. Fluid on T1, it will be low, on T2 will be high, and in proton density, it will be intermediate. But how can we discriminate between those sequences and the FLAIR sequence? To use this, we need to know another point of differentiation, which is the signal intensity of the white matter. We can notice the thin arrows refer to the in the frontal lobe refer to the white matter signal intensity. The white matter normally has a bright signal on T1 and low signal on T2 and the proton density. And this is a very important point. If we see the FLAIR sequence in the last image, we can find that the FLAIR take one criteria from T1, which has a low CSF signal intensity indicated by the yellow arrow in the old image, indicated by the yellow arrow in the FLAIR image. And at the same time, the white matter on the FLAIR sequence has a low signal intensity like T2 or similar to the T2 pulse sequence. And we remember that FLAIR is T2 is like a T2 is similar to T2 on the TR and E, but it's more longer in time. So FLAIR sequence, to discriminate it, you will find it includes one criteria of T1, which has a low signal intensity of CSF, and on the same time, a low signal intensity of the white matter similar to the T2 pulse sequences. And please note this is a common sequence because when you see the FLAIR sequence for the first while, you say, oh, it's a T1. No, to say a FLAIR, you should discriminate these 2 points, the CSF signal and the white matter signal. If the white matter is bright, so you are dealing with a T1 sequence. But if it is low, so you are dealing with a FLAIR sequence. Okay, after we have discussed the spin echo family and the part of the fat suppression techniques and give a hint about inversion recovery sequences, let's discuss the second family, gradient sequence. Gradient sequence has two common sequences and two important sequences, what we call T1 gradient sequence and T2 star gradient sequence. Here we call T2 star gradient sequences. In fact, we find that T1 gradient sequence could be divided into two main groups, Dixon method and the chemical shift technique, which already belongs to the fat suppression technique, but it's actually they are a gradient T1 sequences. A T1 gradient sequence, one of the commonest sequence belong to this group, as we have mentioned, what we call the chemical shift. Actually, the chemical shift has a longer name. It's called T1 weighted dual echo gradient recalled sequence, but we use the simple name. It's called the chemical shift. Another sequence belong to this group, what we call the Dixon methods. It's already T1 gradient sequence. And both sequences are important sequences, especially in the body imaging and in routine body imaging. Why? Because it had the ability to detect the fat and quantify its amount. So these are routine sequences in the body imaging. So let us discuss the chemical shift sequence. Chemical shift, its main function to detect the microscopic or intracellular fat and we discussed already the major types of abdominal fat in the previous slide. It composed of two components, or it produces two sets of image. One set or one group of image, it's called in-phase images. The other images or other group called out of phase or opposed phase images. So it produced two groups of images. One of the important artifact which is linked to the chemical shift sequence, what we call the India ink artifact. So what's India ink artifact? India ink artifact appears only on the out of phase or opposed phase image. It doesn't appear on the in phase. And it is a dark line delineating the abdominal organs when interfacing with the macroscopic fat. This is an example of a chemical shift sequence. As we have mentioned, it produces two group of image. On the right side, on the left side of the image, we can find that this is in phase. We call it in phase image, and the other image we call it opposed phase or out phase image. How can we discriminate between them? If we notice the yellow arrow refers to a dark line. This dark line, you can find it in almost of the image. It present in the surrounding the upper pole of the left kidney, the inferior margin of the pancreas, and the inferior surface of the liver. So this is what we call the India ink artifact. And as we mentioned before, this is line appear on the opposed phase image only when the organ interfacing with the macroscopic fat. So this is the opposed phase image. So what about the white arrow refers to? The white arrow refers to the right adrenal gland soft tissue lesion. In the in phase image, the this lesion exhibits a relative isosignal intensity to the liver, while on the opposed phase we find that its signal become very low compared with the in phase. This is indicate that this lesion contains microscopic fat, and this is very important. By this sequence we detect the component of this lesion. So this means that this is a diagnostic in the common scenarios for adrenal adenoma. So from here we can see the importance of chemical shift sequence. This is another example of chemical shift sequence. This is a normal scans of the upper abdomen, reveals the in phase and the opposed phase, and how can we discriminate between them? If we notice the dark line indicated by the yellow arrow in the opposed phase image, this is what we call the India ink artifact, which is not present on the in phase image. And this line appears as long as there is interface between the abdominal organs which containing water and the macroscopic fat, and we will discuss the mechanism of its formation later. So this is an example of chemical shift sequence and two phases and its two components. If we check this diagram and imagine that the yellow color represents the abdominal fat into the abdomen, and the lesion has two components, fat and water components. And when applying the chemical shift sequence on that lesion, we'll find that during in phase, the water and fat components, each one of them will give signals. These signals will be directed to the same direction. So the signal of this lesion become more brighter, and the signals are additive to each other. While on opposed phase sequence, the signals of both water and fat will be directed to the opposite directions. So their signals cancel each other. So the signal of the lesion will be darker on the opposed phase. So any lesion has microscopic fat should has homogeneous drop of its signal in the opposed phase sequence. And also we can notice the dark line which encircling the lesion, which represent the India ink artifact as we discussed it before. If we check this diagram, we'll find that we have a lesion with only one component, water component. There is no fat component. So we have one group of the signals. Its intensity and the brightness will not change from in phase or on the opposed phase sequences. So there is no drop of the signal on the opposed phase will happen as happened in the previous lesions, because only we have one group of the lesions of the same degree of the signals and the same degree of the brightness. Okay, let us discuss the formation of the India ink artifact. If we have a scan of the abdomen, and this scan contain abdominal fat, and at the same time contain any abdominal organs like liver or kidney, and these organs usually contain water. So we have two components. We have water component in the abdominal organs and the fat component in the abdominal fat. We have usually we have an intersecting part between the water component and the fat. So at this part or this interface, the India ink artifact is formed because there is cancellation of the signal on the opposed phase at this part. So the dark line is formed here. In the image, this part we call it pixels and voxels. So this part of the voxel which represented by the India ink artifact or the dark line. So simply India ink artifact is present exclusively in the opposed phase image and present at the interface between any organ contains water and its interface with the abdominal fat. Okay, let's talk about the Dixon sequence or Dixon method. It is a recent technique developed in the last years and based also on the chemical shift sequence. So it produces the in phase and out of phase group of image. However, it produces more groups of image. Its advantage over the chemical shift is that it gives more homogeneous suppression of the microscopic fat over the chemical shift, and it is less susceptible to the artifact. So it gives a better and sensitive suppression of the microscopic fat. And it formed from four group of images. It gives four group of images, what we call water only image, fat only image, in phase images, and opposed phase image. So it's based on the chemical shift too. It's important it can be used for detection and quantification of the amount of the fat. So we can use it for assessment of the fatty liver case scenarios and see is it progress or a stationary course or decrease. So it has advantage in the quantification of the abdominal fat. This diagram demonstrates the four components of the Dixon method, including water image only, fat image, in phase and out of phase images. This is an image of what Dixon actually do. There are four group of images. Dixon fat image. Here we can notice that the fat is bright in signal, and in the water image the fat is suppressed and it looks like T1 with fat sat, in addition to the two sequences in phase and out of phase with the characteristic India ink artifact at the out of phase image. So we have talked much about the detection of the fat, so let us summarize it. Detection of the fat could be done for macroscopic fat or microscopic fat. Macroscopic fat could be detected by fat saturation and FLAIR sequences related to the spin echo family, and the microscopic fat related to gradient echo family, so could be detected by chemical shift and Dixon method. So what about the T2 star gradient sequence? T2 star gradient sequence is a sensitive sequence to the smallest changes in the inhomogeneity in the magnetic field, and it can improve the rate of small lesion detection. So for example, if you have a lesion with microbleeding contains oxyhemoglobin or lesions with iron deposition, all these structure oxyhemoglobin and iron deposition have a paramagnetic field, so produce inhomogeneity of the field. T2 star has the ability to detect what these structures which causing this inhomogeneity of the field, because it has a long TE value, so it can accentuate the local magnetic heterogeneity or inhomogeneity. Additionally, so the commonest clinical applications are the detection of the iron microbleeds and the calcification. This is an example of T2 star gradient sequence, what can detect. On the left side of the image with the blue arrow refers to a foci in the brain. So this is low signal foci, so this indicates a part of microbleeding. And the other image with multiple yellow arrows, this is a case of amyloid angiopathy and shows the multiple innumerable low signal foci of signal void, which is microbleeds, and the large areas at the basal ganglia refills to the calcification. This is usually couldn't be detected with the conventional MRI sequences T1 or FLAIR or T2. This is only could be detected. This pattern could be detected on the by T2 star gradient. So T2 star is important sequence, especially in the brain imaging. Now let us discuss the contrast studies. Contrast studies, it means that you will inject gadolinium through IV, gadolinium administration. So what are the sequence used with the gadolinium administration? Actually, we can use special sequences related to spin echo or special sequences related to the gradient sequence. Sequence related to spin echo family, it's only available with T1 sequence. You can use it with FATSAT or without FATSAT. This is based on the case scenario. If you have a fatty lesions, you may need to suppress the fat signal and you make injection of the gadolinium. If without fat, you can use it without FATSAT technique. While the gradient sequence, we have two sequence, two 3D gradient T1 and 2D gradient T1 sequence. In the body imaging, we prefer the 3D gradient sequence. 3D gradient sequence is the preferable for the body imaging. Usually why? Because it's faster, short in time, and has a more sensitivity than T1 in the detection of the contrast enhancement. Additionally, we can use 3D gradient for reformatted or post-processing of the image. We can do reformatted image, coronal, sagittal, or whatever. So 3D gradient is a preferable technique for contrast study in the abdominal study, while T1 usually used for almost the remaining modalities. This is an example for T1 with contrast. This is a coronal MRI of the brain. We can see the blue arrow refers to fairly defined suspicious area on the brain. However, after contrast, the suspicious area of the lesion shows significant enhancement and they become more delineated and more obvious. So we can, by reading all the image, can do the appropriate interpretation. So this is an example of T1 with contrast without fat sat, because we can see the subcutaneous fat on the neck. The fat is still bright on both sequences, so there is no fat saturation in this example. Another example of the abdominal study, here we can see the image symboled by A. This is a T2 with fat sat, and we know why it is a T2 with fat sat, while the remaining three pictures or images B, C, and D, B is pre-contrast with characteristic fat suppression, so it could be T1 with fat sat or gradient sequence, but actually, as we said before, we prefer in the abdomen 3D gradient sequence technique. So this is a 3D gradient sequence technique in the pre-contrast, while C, it represents the arterial phase, and you can see clearly the aorta and the IVC and the kidney and the parenchymatous organ all show significant enhancement, and this enhancement pattern continue to the venous phase in the MHD. So this is an example of the gradient, 3D gradient sequence image. Finally, I'd like to give you a hint about the different names of the pulse sequences provided by the major vendors company like GE, Philips, and Siemens. You will find there are these all pulse sequence could have a different names according to the machine and according to the company produced. If we see this table and the coming table, you can bring it from the net. You can find that, for example, the spin echo had the same abbreviation in the all components, while the fast spin echo in the Philips it's called turbo fast spin echo, while in the GE it's called fast spin echo. So you can have a different names, and this is another table which can explain the different names of the pulse sequences according to the machine you have, so you can check it and you know what type of machine you have, so and you can use the the appropriate name for each sequence we have discussed. Finally, I'd like to thank you for, and hopefully you found this lecture is of value for you. See you in the coming video.